Alright, so now we're going to talk about what can go wrong during a pregnancy or a delivery. So the first one is a spontaneous abortion. So this is another word for a miscarriage. So this is whenever delivery of the fetus before it's viable, which is around 20 weeks of gestation. The signs and symptoms that you're going to see with a spontaneous abortion is going to be cramp-like, lower abdominal pain, vaginal bleeding that could be bright or dark. What does it mean if they're having a bright red discharge? Okay, arterial blood.
Wait, what?
Dark versus bright blood.
Bright would be like arterial.
Okay.
Dark, venous.
Yeah, could also be new and then older blood, right? Depending on the position of where it is. Also passage of tissue or blood clots. So you're going to see all of this with a woman experiencing a spontaneous abortion. So these two emergencies are very similar. They kind of sound the same, but we're going to talk about them both at the same time because most of them happen in different ways, but they have the same symptoms and side effects. So for placenta previa, that is whenever the placenta is going to be attached near the cervix, as you can see in this picture. There's going to be severe bleeding, and then the eruptio placenta, so there's going to be a lot of bleeding surrounding the uterus, which causes the placenta to detach itself. And so in this case, the bleeding is going to be minimal. The way that you can remember these, because whenever you're assessing a patient, you can't tell which one of these, or which one is placenta previa and then the abruptio placenta. With abruptio placentae, they're going to be experiencing pain with bleeding. With placenta previa, there's going to be bleeding but no pain. So that's how you should remember these two. They sound really similar, so it also makes sense. Abruptio sounds worse, so there's going to be pain with bleeding. Alright, so what are the differences between those two, placenta previa and abruptio placenta, without looking at your notes?
No pain.
Previa and pain. Okay. What about what occurs when those two?
Previa is like for the placenta is covering the cervix and baby's on it.
Okay. And then the other one?
The other one where it detaches.
Okay. Cool. A ruptured uterus. So it's whenever the uterus ruptures, obviously. The uterine wall is thin, so like we said before, we could easily poke it, right, even whenever it's presented. This is usually caused by trauma, so just know that this could be a reason for excessive bleeding. Also know that this is a high mortality rate, requires immediate surgery, and like we said, caused by trauma. Another one is ectopic pregnancy, so this is very serious. This happens early on in a pregnancy. So it's a pregnancy or implantation of a fertilized ovum outside of the uterus. So as you can see here, it's the outside of the uterus wall, in a fallopian tube or in an ovary. Development of the fetus is not possible whenever someone is experiencing an ectopic pregnancy. You really want to catch these early on, but a lot of the times the mother is either not aware that she is pregnant, so this can be very dangerous because once the fertilized ovum starts expanding, it's going to rupture any one of these structures, so that can cause a lot of bleeding, right? So with an ectopic pregnancy, they're going to have localized pain in one area. So like we said before, whenever we're doing our patient assessment, we really want to ask the woman where the pain is located. We want to see if it radiates anywhere or anything like that. If she's having pain on her left side, then we can expect that there's an ectopic pregnancy on her left side. So that's why we really want to be as detailed as possible whenever we're assessing for pain. Of course, there's going to be vaginal bleeding, tenderness or bloating in the abdomen. There's going to be a palpable mass sometimes where the ectopic pregnancy is occurring. Decreased blood pressure, increased pulse rate, signs of shock, which again we're going to treat with oxygen and keeping the mother warm, discoloration around the umbilicus, and an urge to defecate. So the next one, they sound the same, but one of them is a more severe form of the other. So preeclampsia, so whenever the mother is having high blood pressure, this causes a excess of protein in the urine to occur after or during the delivery. A severe form of preeclampsia is eclampsia, and after the progression of the preeclampsia, you're going to see seizures in this stage. So preeclampsia, no seizures; eclampsia, seizures, and its result, the result of that is because of the high blood pressure. So that's how I remember those: seizures, no seizures. And sometimes there's no cause of this. It could either be genetic or some kind of issues with blood vessels, but it really isn't a cause for this besides that. So with the preeclampsia, you're going to see these signs. So they're going to have blurred vision, excessive swelling of the face, fingers, legs, or feet. This is what's going to kind of give you a hint that this may be preeclampsia. Elevated blood pressure, like we talked about, anxiety. Another difficulty that a woman that's pregnant can be experiencing is something called pregnancy-induced hypertension. This is just a period where the mother's experiencing a higher than normal blood pressure, so above 140 to 90. And yeah, increase in systolic by about 30, diastolic for about 15. So if you're given this term like pregnancy-induced hypertension, I mean, you guys, it's a pretty self-explanatory term, right? So it's not very difficult memorizing this one. The supine hypotensive syndrome, so like we talked about, the weight of the baby can suppress the inferior vena cava. So that's why it's really important that even though this is rare we really want to transport our patient on her side, right, to relieve that pressure on the inferior vena cava. What happens is that there's going to be reduced blood flow to the right atrium, which decreases the preload of the heart, and so by this, the woman could be experiencing signs of shock and a decreased cardiac output. So like we said before, to avoid it, we want to position her on her side with towels or a wedge if she's on the backboard, making sure to elevate the hips to prevent the weight of the fetus from suppressing the inferior vena cava. So signs and symptoms of abnormal delivery. So any fetal presentation other than the crowning of the head would be considered abnormal. So if you see a little hand out there or a foot, their buttocks, that's going to be abnormal. Usually the majority of babies are delivered with, it's called a cephalic delivery, so wherever the head is going to be presented first. Cephalic, C-E-P-H-A-L-I-C. Yeah, cephalic. Abnormal color of the amniotic fluid, which we're going to talk about later what that means. And then any labor that's going to be before 38 weeks of pregnancy. So normal pregnancies last, like we said, 38 to what? 40 weeks of pregnancy, yes. So like I said before, with breech birth, that's whenever the buttocks are presenting first. And so with this, we can still deliver the baby vaginally. We just have to be extra careful whenever we're delivering the head, because sometimes once the shoulders are delivered, the head can be in a way stuck. So what we're going to want to do with this is we're going to want to insert our hand in this V position to be able to relieve that pressure on the baby's face. Because like we said before, once the shoulders are delivered, the chest expands and the baby starts breathing on its own. So by relieving this pressure on the baby's face, the baby's able to breathe. So a limb presentation is an arm or a leg that's presenting first. This requires an emergency C-section. So whenever we're transporting the patient, we want her to have her knees to her chest. In a way, we're kind of preventing the labor and delivery process, because this is very complicated, and we won't be able to successfully deliver this vaginally. Prolapse cord is whenever we see the umbilical cord presented first. And so with this, again, it's rare, but it could happen. And so what you want to do is instruct the mother to not push. Sometimes what you can do is you can put your hand in there and try to feel for the umbilical cord. If you relieve pressure, the umbilical cord, sometimes you can feel a pulse. And so that can mean that it kind of means you just have to keep your hand there, right? If you feel a pulse. If you don't feel a pulse, then like I said, try to put your hand in there to see if maybe you can relieve that pressure to bring back the pulse. If not, then that could be a more serious issue that you probably don't have to deal with in this case. So it's really important to just transfer the patient and relieve as much pressure as you can from that cord. Multiple births, so be prepared for twins, triplets, whatever number. But what you'll notice is that after the first delivery, the abdomen is still going to be very large, and so you should suspect, unless the mother doesn't know that she's having twins, usually she'll tell you, oh, I have twins. But if she didn't have any prenatal care, she wasn't aware, then always prepare for that. There's going to be uterine contractions right after the delivery of the first infant. And then, in general, the infant size, whenever they're twins, it's a lot smaller than if it was only one infant. So just take that into consideration, that you may or may not have to do CPR in this case. So Meconium staining, so sometimes the stress can cause the infant to, in a way, use the restroom inside of the amniotic fluid. So you'll see like a greenish, yellow, sometimes even black color when the amniotic sac. So that's why whenever we're doing our assessment, we really want to make sure to ask the mother what color the discharge is, because it could be hinting at meconium staining. And it's really important that whenever you're delivering and you do see this yellow greenish fluid, we want to suction the baby as much as we can, because if the baby aspirates, that it can cause infections. So suction as necessary. And usually if the baby is crying, we don't suction, because they're already getting all of that out of their airway. But if you notice that they're not crying, then you're really going to want to suction and try to focus a lot on getting their airway open. This should all be review, right, from last year. Do you guys remember most of this? Mm-hmm. Yeah. Premature birth before 38 weeks of gestation, or maybe weighing less than 5 pounds. Yeah, and just know that premature infants, their immune system isn't completely developed, so we really want to be as careful as possible, keeping them warm, keeping them in a sterile environment, because they're not as used to all these allergens in the air, or these bacteria that's around them, so be very aware of that. Also, in your OB kit, there should be a plastic, not plastic, it's like sort of like an aluminum looking blanket that can help a lot in keeping the baby warm. Have you guys seen that? No? So it's just like it's not made out of aluminum, but it's like a shiny blanket. I think, I'm not sure if it's here. they surprisingly, yeah, no, it's not here, but they surprisingly keep you really warm, so it's very important to, if you do have that, to use it for the baby. Oxygen as needed, again, using the blow-by technique, right, about an inch away from the nose and the mouth. Post-term pregnancy is beyond 42 weeks of gestation. So normal is 38 to 40, but then once you get beyond that, complications can occur. Precipitous delivery, this is a term that I was talking about. It's a fast delivery. So this can, like we said before, it can cause trauma to the mother and the infant. So just be aware that of the bleeding and controlling the bleeding and all of that. What else? I feel like most of this we already talked about. Okay, shoulder dystocia. So this is whenever the baby's shoulders are larger than the opening, in a way they kind of get stuck. So with this, they do a specific maneuver to try to help the baby out, and you're not responsible for knowing that, but just know that this can be a complication that can happen. And there's different maneuvers that doctors usually use to be able to get this baby out, but most of the time it's that baby ends up fine. So premature rupture of the membranes, or PROM. So this is a spontaneous rupture of the amniotic sac. Like we said before, oh, there we go. Yeah, so you'll see these are really good at keeping really anyone warm. Whenever I worked at this event in Dallas as an EMT, there was this woman and she was really cold. She was going into shock, and we actually used this, and she warmed up pretty quickly. So it looks very thin, and like it wouldn't really keep you warm, but you'd be surprised they do a pretty good job of doing that. So. You guys haven't seen this? No? It's kind of weird. You look like an alien walking around. Yeah, so like I said, you really want to, what they usually do with this is they do like there's like a name for it. Well, anyway, and just know that there can be an increased risk of infection whenever this happens. Embolism, so sometimes there's an increased risk for blood clots. So, like I said, all you're really doing here is just treating for any symptoms or signs that you see, especially just treating for shock. But just know that embolisms are more common in pregnant women. Again, access do the SpO2 levels, the skin, capillary refill, all of that to be able to treat these sort of complications. Okay, so now it gets to the important part. So Apgar. So do you guys remember this from last year? Mm-hmm. Yeah. Someone explain it, like summarize it.
I actually don't remember.
It was like
when the baby comes out and you do assessment of it and you're after.
and then you do it again like 5 minutes after, something like that.
Yeah.
Wait, what?
So I'll explain it. So in the first minute after the baby is delivered, you're going to want to assess them using the Apgar, which means, can you guys see this? I'll just put the lights down. So A is appearance. So after the baby comes out, after a minute, if they're blue all over, they get a score of 0. If their extremities are blue but their torso is pink, then they get a score of 1. Score of 2 is no blue coloration. So this is just assessing the circulation. And then pulse, if there's no pulse, then they get a score of 0. Score of 1 is above 100 beats per minute. So again, you have to really know the normal ranges of pulse for a baby. Grimace, so this is pretty much, you do some sort of stimulation of the baby that either causes them to cry or some sort of reflex, and I'll show you guys a video after this, but just know that if there's no response, score of 0. If they cry but it's kind of a weak response, then they get a 1. Score of 2 is a full stimulation, full reaction of that reflex, And then activity, no movement. If the baby's just standing still, they get 0. 1 movement is if, or 1 score of 1 is if they're sort of moving. And then active movement, they're over there moving their arms around, crying, score of 2. Respiration, like I said, if they're crying, they get a score of 2, like strong cry. Kind of weak crying gets a score of 1, and then no breathing at all, score of 0. So I remember there was definitely, this is really important for the OB section of the National Registry. So that's why we just shortened it to Apgar so you guys can remember. But I'm going to show you guys a video of the Grimace part of this because there's different ways that you can test to see these reflexes that are normal in a baby. So, yeah. This one's the easiest for me to remember, so you just kind of touch their cheek and they'll turn to the side. That one actually. This is another easy one. They just grab your finger. Yeah, so those are the ways that you can test these primitive reflexes. Okay, so 7 to 10 points, you do the usual routine care, so that's a good score. 4 to 6 points, you may need to stimulate more, like the baby to cry. Sometimes you can rub their back or hit their foot, and that kind of stimulates them to cry and increase that flow of oxygen. 0 to 3 points, you may need to provide CPR, ventilate the infant, do chest compressions. So 7 to 10 points is what we're really looking for here. Like I said, if you rub the baby's back, this kind of stimulates them to cry or hit the bottom of their foot. After, like a few minutes after the baby, after the birth, you'll see an increase in SpO2 level like we talked about. So just be aware of this, is that their SpO2 reading isn't really going to be normal until after 10 minutes. But we really want to look for the SpO2 levels above 92% or 94% in this case. And then whenever we do have to provide CPR, you guys remember how to do that, right? What's the rate of compressions to breaths? 15 to 2 using your fingers. And then either the fingers or putting both of our hands around the baby's chest and using our thumbs, right? 15 to 2. Or 40 to 60 per minute, breaths per minute. And we really want to reassess every 30 seconds. And just know that for a baby, their heart rate is going to be elevated and their respiratory rate is going to be elevated. So we really want to keep the compressions at 120. Usually we look for compression rate of 100, right, for like adults, but for this case it's really important to keep that 120. But I think that's it. Yeah. Also, if the rate drops below 60, we really want to, that's when we're going to start CPR and really try to get that blood flowing and oxygen in the baby. But that's it for this. This went by faster than I thought. Let me see if I think the most important part here is this Apgar chart thing. You guys do have to memorize this, and I think for the Grimace part, what I mostly remembered was, again, the maybe grabbing the fingers or you stimulating this reflex where the baby turns its head, and yeah, that's pretty much it. So what are the differences between placenta previa and eruptio placenta? Again.
Previa, it's over the cervix,
Okay. Eruptio is detaches, yeah. Oh, okay. Alright, so for one rescuer for an infant, it's 30 compressions to 2 breaths, and for 2 or more, it's 15 to 2. So that's a correction. I feel like they change it a lot, but just remember 30 to 2. So same as adult. And then 2 rescuer, 15 to 2. But yeah. Any other questions over anything? I wrote down all the complications that can occur there. That way you guys can kind of have it all there. I didn't talk about breech birth or limb presentation, or I didn't write down breech birth or limb presentation on there, but these are the ones that I think, or at least I struggled with whenever I was studying. But if you see them all there and you try to memorize it, it'll be a lot easier, because like you guys know there's an OB section, like a whole entire OB section on the National Registry, so this is going to be really important for you to know, as well as, you know, reading over the chapter. Even after this class, if I missed something or if you didn't understand anything, there's really a lot in this chapter, so feel free to ask any questions. Everything's good?